This is a lecture on understanding early pregnancy ultrasound reports by me, Dr. Caroline Prentice. So the things that I'm hoping to cover today are the basics about how ultrasound works, the terminology that we use to describe images in ultrasound and what these images might look like, how an ultrasound report is structured and how to access that key information, and we'll look at a few clinical examples. So this is a really simplified diagram of how ultrasound works. So you have the probe, which bounces sound waves through the skin and into the body. So it's important that the probe is in contact with the skin. Any air will stop it from working. So that's why we use the ultrasound jelly, because it helps transmit the sound waves. The sound waves then bounce off the targeted area that we're looking at, and the probe then receives these sound waves back, and they're processed within the ultrasound machine itself. So here we have the ultrasound machine. So it does look quite confusing, there's lots of buttons, but basically the machine is interpreting the sound, bouncing back, and then translates that into a grayscale image. There are lots of different functions, and these are mainly to optimize the images. So you can change the depth of what you're looking at, whether you're looking at something very close to the probe or something very far away. You can zoom it in, zoom it out to try and get a better understanding of what it is that you're looking at. You can change the focal point and the brightness, and all of these are to optimize the image that you're looking at and work out the most accurate way of getting a picture. The other options are for measuring and labeling. So it's part of the medical record, and for medical legal purposes, it's quite important that you carefully label. So if you had to, you could go back and say, well, this is what I was looking at, this is what I was measuring. There's a Doppler mode, and this measures essentially blood flow, and it'll represent it as a colour. So red and blue, depending on whether it's going to or away from the probe. And then also the brightness. So the brighter, if it comes up bright green, that's a really high flow area. There's different probes that you can use. So we've got abdominal probes and vaginal probes, and I'll come along and we'll look at those differences in the images in a while. So a little bit about the anatomy. What are we actually looking at when we're doing ultrasound scans? So the majority of women will have an anteverted uterus, so that's a womb that points forward, and about 20% of women will have a retroverted uterus. So the fundus of the uterus points back towards the spine rather than forward towards the abdomen. So these are pictorial representations of vaginal scanning. So that's the majority of the scanning that we do is going to be transvaginal in early pregnancy. So you can see there the body of the uterus there in red, the cervix, the bladder, which will look like a sort of black area where the fluid is, the endometrium down the middle of the uterus, and then the bowel, you'll get a lot of sort of moving shadows, and that represents the peristalsis of the bowel. And sometimes if you've got too much bowel gas or too much peristalsis, it can affect the image that you have. So here I've just drawn these over a real life image, so you can see roughly what we're looking at, just to compare the two structures there. So the previous slide was in a longitudinal view. This is a transverse view. They're useful for looking at different parts of the anatomy and for understanding a 3D relationship of structures. So now we would have the bladder at the front, the bowel at the back, the ovaries laterally, and then you can see how the shape of the uterus changes when you're looking at it in a transverse view. So an adnexal view is where we would sweep in a transverse plane and then out to the side. And what you're looking at there, you can see you've got the uterus there labelled as uterus transverse section. The left ovary, you can see a little ectopic sitting next to the ovary there, and then the bowel at the back. And this is commonly when we're doing a sweep out to the side to look for adnexal pathology, look for ovarian cysts and things like that, because you won't typically always see it all on one image. So moving on to pregnancy, what do you expect to see when we're scanning in early pregnancy? So the first part that develops is a gestation sac. So this is the black area that you can see just here. It's got a decidual reaction, and this is this bright white outline, and that's the endometrium, the lining of the womb, reacting to the pregnancy implanting. It's useful because you won't see a decidual reaction in a pseudo sac that you can sometimes see with ectopic, where you've just got a collection of fluid. It won't have that decidual reaction. You can see it's round and it won't be mobile. So if you were to give gentle probe pressure, it's not going to slide through the cavity. Again, something that you'd see with fluid, or that you can see in miscarriage if the sac is actually on its way to being passed out through the cervix in miscarriage. So when you're looking at the gestation sac, we'll also take some measurements. So you can measure the MSD, or the mean sac diameter, and that will give you a rough estimate of the gestational age. So I've just put one image on here, but you would measure it in 3 planes to give you the mean or the average size. Next thing that develops within the gestation sac is a yolk sac. So you can see this smaller sac within the sac, and that's the first part of the pregnancy to develop. So once you've seen a yolk sac, you can be pretty certain, or in fact definitely certain, that this is an intrauterine pregnancy, because a pseudo sac will not have a yolk sac within it. So here you can see we've taken a measurement. We've measured the mean sac diameter, and that's given us the gestational age. So we've measured it 2 planes here, 1, 2. We've then turned the probe 90 degrees to measure it in the 3rd plane, and that gives us an average. So you can see based on the MSD, the mean sac diameter of 12 millimeters, that roughly equates to a gestational age of 6 weeks and 1 day. Once you've had the yolk sac develop, you will now start to see the fetus and the fetal pole develop. This will always develop next to the yolk sac because they're part of the developing pregnancy. Once you've got a yolk sac, you then wouldn't measure the mean sac diameter. And similarly, once you've got a fetal pole, you don't need to go on. You don't need to measure the sac or the yolk sac. So you can see here we've measured the crown rump length, which is a measurement from the top of the head to the tip of the bottom. And that's also given us a gestational estimate, so gestational age of 6 weeks and 6 days there. Sometimes it's called, you might hear it called a fetus or a fetal pole. They just mean the same thing as the earliest part of the developing embryo. So once you develop that fetal pole, what you'll see is the heartbeat. So these come at a surprisingly early gestation, so even around 6 weeks you should see a heartbeat there. So you can see here in the middle of the video just that fetal heart pulsation in the middle of the fetal pole. So looking here, we're comparing a 7-week pregnancy, a transabdominal, comparing it to a transvaginal scan. So you can see here this sort of a wider crescent indicates that this would be a transabdominal scan, and then this much more circular here is the transvaginal scan. And you can also see it flips the image upside down, so you're measuring from the top down for an abdominal scan. Some people measure the other way up with a transvaginal scan. It doesn't really matter as long as they're familiar with the way that they're doing it. And you can see that you just get a lot more detail on the transvaginal scan, so there's less tissue that you're scanning through, less time for the sound waves to be redirected, so you get a more detailed analysis of these small internal structures. You can even see the amnion developing around the fetus there. So as things develop, you're generally now just expecting the pregnancy to get fetus to get bigger. So between here you've got a fetus of 8 weeks. This is 16 millimeters in length for the fetal pole. You can see this is the vaginal scan, and then here on the abdominal scan we're talking at a 9-week fetus now, so 24 millimeters in length. And you can even start to see a better differentiation between the head and these little limb buds appearing as well. And then as we come on to 10 weeks, you can see structures a lot more clearly. So you can see definite limb buds, you can see the abdominal wall, the heart pulsation is a lot clearer, and you can even see structures within the head there. And this video is just demonstrating, you can see this really obvious fetal heart in the middle of the fetus there. So this is 38 millimeters, so approaching 4 centimeters long at about 10.5 weeks. And so here we have a 12-week scan. So these are the images you'll probably be more familiar with. And this is when most people would have their first pregnancy scan if they haven't had any problems with pain or bleeding. So we're measuring here a crown rump length, and you can see that's 65 millimeters, so just over 6 centimeters. And you can see that this looks much more like a recognizable fetus shape. So you can see the head, you can see the brain, you can even see little arms and legs and the umbilical cord, and then a really obvious heartbeat there in the middle at 12 weeks. And these are both transabdominal scans. So the progression that we're expecting to see in a normal, viable early pregnancy is firstly a gestation sac, then a yolk sac developing within that gestation sac, a fetal pole developing alongside the yolk sac, and then you're seeing an enlarging fetus with more features, and you'll see the amnion, that extra sac developing around the baby. So moving along now to think about how we diagnose a miscarriage based on ultrasound. So sometimes you have what we call an anembryonic pregnancy, where you just have the gestation sac developing, but you can't see either a yolk sac or a fetal pole within it. And if the mean sac diameter reaches greater than 25 millimeters and there's nothing inside it, then you can diagnose miscarriage based on that scan. If you can see a fetal pole within the sac on a transvaginal scan, if you've got a CRL of greater than 7 millimeters, you should definitely be able to see a heartbeat. And this usually equates to around 6 weeks gestation. So if you've got a CRL of greater than 7, you can't see the fetal heart, then you would diagnose a miscarriage. Sometimes you might not have great views, or the measurements might not be accurate, in which case you can always offer a rescan. If for some reason a woman has declined to have a vaginal scan or on a transabdominal scan, if you can't see the fetal heart, what you would tend to do is then measure the crown rump length and then offer a second opinion scan or rescan in 14 days to see if there's been any further development. You can consider a second opinion as well. And so on that second scan, if you still can't see a fetal heartbeat, then you would diagnose miscarriage. The reason we have these criteria are to try and reduce avoidable harm. So basically, you wouldn't want to intervene with management of miscarriage if there was any possibility of this being a viable pregnancy. So that's why we have these careful criteria, and these are based on the NICE guidelines. So you can see here, this is the Doppler window that's been put on. So as I briefly mentioned earlier, this is assessing blood flow. So you can see here in the uterus, there's evidence where the maternal vessels are. They've got blood flow here, so going towards and away from the probe. And within the fetus here, you would expect to see a heartbeat, and they're just showing that there's no heartbeat there. It's a vaginal scan. You can see that the CRL is 22 millimeters from the top of the head to the rump. So you would definitely expect to see a heartbeat if one was present. So you diagnose miscarriage based on this scan. So there are other features that you see that, although they're not diagnostic, they do demonstrate a poor prognosis. So you would still have to meet the definite scan criteria, but seeing these things would make you think this is more likely to be a miscarriage than an ongoing pregnancy. And it might just change how you counsel that woman, but you would explain that you would need to make that confirmation diagnosis. So the things we're looking for here is if this is significant earlier or smaller than expected for the gestation. So you might be scanning somebody who is, say, for example, 10 weeks pregnant, but they're showing up as 5 to 6 weeks. The CRL is only 5 millimeters and you can't see a fetal heart. So that's a little bit worrying. You wouldn't be able to diagnose miscarriage, but you would say to them, this is looking significantly smaller than your dates. Seeing an enlarged yolk sac is another sign of poor prognosis. If the gestation sac itself has an irregular outline, if it's very low in the cavity or low in the cervix, maybe it's already being passed in a miscarriage. And whether there's bleeding or an area of hematoma around the sac, that's another poor prognostic sign. So here you can see there's a hematoma that's developed next to the sac. So you've got the gestation sac, and then you can see it almost looks like another sac next to it, but it's actually an area of bleeding. And this is where the bleeding has happened around the sac. Sometimes the pregnancy will survive and it'll go on to be a viable pregnancy, but it can be a sign of miscarriage. So it's important just to bear that in mind. This is showing a very enlarged yolk sac, so you can see that the yolk sac is almost as big as the gestation sac itself, and there's just a very tiny fetal pole on the outside there, and this pregnancy was miscarriage as well. Here we've got an example where you've got a very irregular sac, so you can see it's not that smooth oval shape. It looks like it's already starting to collapse. And here you've got this really enlarged yolk sac again, and then some other structures here. These are possibly evidence of bleeding or little strands of blood, or even a disorganized fetal echo there. It's difficult to say. So with miscarriage, sometimes the sac may be completely collapsed. There may be evidence of blood clot or retained products of conception. So these are either clots or tissues that have been left after miscarriage, so an incomplete miscarriage. We would generally say they're significant if it's more than 15 millimetres. So even after a complete miscarriage where all of the pregnancy tissue has passed, you're going to have some thickened endometrium and some blood or clot within the cavity. So once it's more than 15 millimetres, we would say that's significant. Sometimes there can still be blood flow, so if there's placental tissues that are still active, you may still get some blood flow within those tissues. We would often describe it as mixed echogenicity, so irregular greys, blacks, uneven looking. And you can get the sliding sign. So with gentle probe pressure, you'll see these tissues sort of sliding in and around each other, which would suggest that they're not attached, but they are trapped within the womb. So here you can see all of this area in the middle marked out by the yellow markers is retained pregnancy tissue. There's still some blood flow, but there's no definite pregnancy sac that you can see. This is possibly a collapsed sac here. And this was retained products of conception after miscarriage. The other thing we just need to bear in mind is a molar pregnancy. So this is disordered growth of placental tissues. You often get very high blood flow. There can be a sac, so with a partial mole, you'll have a pregnancy sac and then molar tissue adjacent to it, or a complete mole where the whole uterus is just filled with disordered placental growth. It's often described as multicystic, so lots and lots of cystic spaces, lots of those little black circles, black areas. It can look like a snowstorm appearance, so it's where you've got this heavy blood flow, so you can just see this very disorganized tissue, but with active flow. Sometimes it's described as vesicular, so lots of vesicles or grape-like looking. And they do usually have a high Doppler and colour uptake. So when you put the colour flow on, it's lighting up really, really bright, and that's because of the its disordered overgrowth with a very good blood supply, early stages of tumour development. So here you can see the uterus is filled with these lots of little, what look like little gestation sacs or little cysts. There's no recognisable gestation sac within there, and there's no fetus that you can see. When you put the colour flow on, you can see, compared to just sort of the bits and bobs that were on the previous scan, that there's really bright colour flow, and that's indicated by these kind of yellowy green areas here. And there are these lacuna spaces, all these big sort of dilated cystic areas, and that's a classic view that you'd see in a molar pregnancy. So moving on to the other thing that we're often looking out for in the scanning in early pregnancy clinic, and that's an ectopic pregnancy. So 90% of them are going to be in the tubes, so in the fallopian tubes adjacent to the uterus. There's a couple of different appearances that you might see. So the most common is a heterogeneous mass. So you've got this mix of greys. You often see it where there's been bleeding and clots developed. Sometimes it's more obvious. You've got a gestation sac and a yolk sac. You can also have a whole fetus there with a heartbeat, and that's what we would call a live ectopic, those really high-risk cases. The sliding sign, again, might be described as positive, so that's where you're seeing the structure that you're looking at is moving separately to the other structures around it. So it's important when you're trying to differentiate, is this part of the ovary? Am I looking at an ovarian cyst or a fibroid or something? Whereas actually, if it's completely sliding around under probe pressure, it's more likely to be a mobile tube with an ectopic pregnancy in. You might also see increased vascularity, so blood flow, especially around the edges. So With an ectopic pregnancy, we talk about either a suspected ectopic pregnancy or a confirmed ectopic pregnancy. So if you can clearly see a gestation sac with a yolk sac or even a fetus outside of the womb, this is a confirmed ectopic pregnancy. There's nothing else that this is going to be. Occasionally you'll just see this heterogeneous mass or there's really difficult views, and you might occasionally see these reports as suspected ectopic. So the sonographer or the clinician is telling you, I really think this is an ectopic, but I can't tell you, 100% based on the scan. It can be mistaken for tubal diseases if there's things like hydrosalpinx or an ovarian cyst or even the corpus luteum. Sometimes very pedunculated fibroids as well can have that appearance of an ectopic pregnancy. The next thing we look at if we're suspecting an ectopic pregnancy is free fluid. This can be a normal finding in early pregnancy where it's just this trace of clear fluid. It comes up as just plain black. What we're more worried about is if this fluid is indicating internal bleeding. So is there hemoperitoneum, which is the fancy Latin name for blood within the abdomen, so blood within the peritoneal cavity. And it might be described as echogenic, so it's showing up with bright white echoes, or heterogeneous, there's mixed echoes in there. This is representing clots there within the abdomen. And it may be described as significant, so that's where they've measured it, and it's a large amount of fluid. So you might have, significant echogenic fluid noted, and what the sonographer is trying to tell you is, I think there's blood in this abdomen. So here we've got an example of a heterogeneous mass. So you can see it's not that distinct, it's similar to the structures around it. And here you've got this large ectopic pregnancy here. It's separate to the ovary. You can see there's a gap between the ovary and the ectopic pregnancy. It's not likely to be part of the ovary itself. These ones are much more obvious. So you've got gestation sacs. You can actually, you imagine it like we call it a bagel sign or a donut sign. So you're looking at the tube end on as if it was, cut into slices. And you've got the pregnancy gestation sac within the tube and then the dilated tube around the outside. So you've got these gestation sac or bagel sign ectopics. And here you can see it's quite clearly different to the surrounding ovarian tissue, just sitting next to the lateral blood vessels as we would expect. These are the ones that really worry us. So hemoperitoneum, these are pictures here. So this is blood. You can see it's speckled, it's grey. It doesn't look like that sort of clear black fluid that you would see in the bladder or in a cyst. It's definitely got something in there with it. And here you can actually see this is a clot that is just floating. So you've got blood around the outside and then this clot floating in the middle. So this is indicating that there's been a significant amount of internal bleeding, that this woman is at risk and needs surgical management. So the corpus luteum, you may see this mentioned on scan reports. It's normal. It's a cyst on the ovary that develops where ovulation occurs, and it happens in pregnancy, but also outside of pregnancy during the time of ovulation. So then if you're pregnant, it provides hormonal support, so it releases progesterone to support the pregnancy until the placental source takes over. They can be cystic, they can be hemorrhagic, and sometimes they look quite similar to ectopic pregnancies. So here you can see this is a hemorrhagic corpus luteum, where it has that speckled appearance. And this one's much more cystic, so you can see there's the cyst part in the middle, the ovary round the outside, and then the blood flow. And you can see, if you weren't really paying careful attention to where that is and what it's attached to, how that could be mistaken for an ectopic pregnancy. Just like to move on to some cases now. So we've got a 24-year-old woman. She's her first pregnancy at 8 weeks. She's had cramps with light spotting. She was scanned 2 weeks ago and was a pregnancy of unknown location. So they couldn't see a pregnancy inside or outside of the womb, but there was a positive pregnancy test. Bloods were taken. The progesterone was 67, so greater than 60 indicates a viable pregnancy growing somewhere. The beta HCG levels were taken and they've increased, again, consistent with a viable pregnancy, likely to be intrauterine, but we need to find out on scan. Her observations are normal, she doesn't have any pain. So this is her scan report today. So I've blacked out the patient demographics, but you can see we're rescanning, is this a viable pregnancy? A transabdominal scan only has been perform. So they opted not to do a transvaginal scan if the views were optimal and you didn't need to do a vaginal scan, then you would avoid that invasive procedure. You can see that they've, according to the dates from the period, we should be looking at an 8-week size pregnancy or an 8-week size embryo. And on the assessment, they've got gestation sac visualised, the location is in the uterus. The yolk sac is visualised, the embryo is visualised, and the heart activity is present. The CRL has measured at 14 millimetres, which is within the realms of normality. So these bars here indicate that 95% of pregnancies will lie somewhere within these two markers. So if it was right in the middle, that would be average on the 50th centile. Above there would be above the 95th, and here would be below the 5th centile. So this is within the normal expected range. They've commented that they can't see anything else obvious, no cysts or anything else. So the summary for this report is a single viable intrauterine pregnancy with biometry, so measurements consistent with the clinical dates. So you can reassure this patient that actually this scan is okay, indicates a viable pregnancy, and that fits in with the clinical scenario given. So case number 2, a 24-year-old woman, this is her first pregnancy, she's 10 weeks pregnant, she's had cramps and light bleeding. Observations are normal, urine pregnancy test is positive, and she's had her first scan today. So they've put the indication, the method is transabdominal and transvaginal as well. You can see that they've put the last menstrual period in. The gestational sac has been seen and it's within the uterus, so immediately we're thinking this is not an ectopic or a PUL. The embryo has been visualised and it's commented that the cardiac activity is absent, so they haven't seen the fetal heartbeat. They've measured the CRL, so the crown rump length, and it's 18 millimetres. So when we're trying to decide, is this, what's the diagnosis here? Is this a conclusive scan? We're looking at the fact that it's a transvaginal scan, so it's going to be the most detailed scan that we would have available. The CRL is greater than 7 millimetres, and we can't see the heartbeat. So these three things in combination would suggest that we can diagnose miscarriage based on this first scan. And by 10 weeks, we should be seeing a significantly larger fetus. So by 10 weeks, we would be looking really around, I'd expect to see about 40 millimetres, something like that. So this is well below the first centile. This is much smaller than we would expect for this age. So the summary for this scan would actually be a missed miscarriage. So you can see the whole pregnancy there, it's stopped developing some time ago and they've only just developed symptoms. So this would be a missed miscarriage and diagnosed on this scan. You wouldn't need to necessarily repeat the scan, although sometimes we'll offer it at the patient's request if they feel they need that for their closure. So for the third case, for a 32-year-old woman, it's her first pregnancy, she's 6 weeks. There's right-sided abdominal pain and spotting. Observations are normal and the urine pregnancy test is positive. So on the first scan today, we can see that a transvaginal scan has been performed. So we've got hopefully the most detailed scan that we can get. Inside the uterus, we cannot see a gestational sac. However, they've commented that there is an ectopic pregnancy. They've commented it's in the right tube and given the measurements for the total size of the ectopic pregnancy. So not the gestation sac, but the pregnancy as a whole. It would be nice on the scan if they'd put whether this was whether there was a yolk sac, whether there was a fecal pole, whether it was a live ectopic, because all of these will help us with our management. And it may be worth speaking to the sonographer and saying, oh, can I just check about these features so that you can guide the management. You can see that the ovaries appear normal and there's no free fluid. So this doesn't appear to be a ruptured ectopic. There's no no bleeding within the abdomen, no free fluid at all. So the summary is quite obviously ectopic pregnancy, but actually I would have liked to have a little bit more detail on this scan, and that detail would help you manage the patient. So to summarise, ultrasound's not an exact science. You're getting your sort of best impression of the sonographer. Things can be missed or they can be misdiagnosed, so it's always important to check and corroborate this to the clinical picture. Does this make sense? Are we missing something? Trying to watch people scan in real time, and then if the patients go on to have surgery, comparing it to the surgical images can all help your understanding in the anatomy and the diagnosis and what you're looking at. And think about the measurements as well. So although things may look really big on pictures and on scan, these are often really zoomed in. So look at the actual measurements and think, what would that look like at surgery? What would that look like if this patient were to miscarry, to try and build up your understanding of the whole picture. So I hope that's been helpful. It's really useful to have feedback and to understand what other things would be useful for you in your clinical practice. Some topics that I've got in the pipeline at the moment are molar pregnancy, and then looking at ovarian cysts and how these look on ultrasound and how that compares to how they look clinically when you operate. But thanks for your time today, and as I said, I hope it was helpful. Bye.